Okay, let's go ahead and get started. Today, this is the webinar for the Stanford Trigeminal Neuralgia Patient Support Group. We have this webinar quarterly, and this is the presentation we're going to talk about today. It's a classification of 7 face pain types. What I thought I would do is present today and then answer any questions that you may have. If you do have questions, there's a button on the Zoom video that allows you to submit your questions to me, and I'll answer them in the order that they come in at the end of the presentation. So I'll go through the presentation and then save the questions to the end, and I'll answer them at the end. So for the reason why classification systems are important for face pain is that it helps us as physicians determine the optimal treatment for a patient. Not all types of facial pain are amenable to the different treatment options that are present. And so when we first meet a patient and are discussing treatment options with them, we want to pick the best potential solution for them. And this solution is going to be in large part based upon the type of pain that they have. So if you can classify the pain into a certain subcategory, that gives you, as the physician and the patient, the best chance of coming up with a treatment solution for their symptoms. So the 7 types of face pain that I'm going to cover today are shown here, and we're going to go through them in the order which you see. Type 1 trigeminal neuralgia is what is thought of classical trigeminal neuralgia, and we'll spend the most time talking about that. Type 2 trigeminal neuralgia is generally an extension of type 1 trigeminal neuralgia, meaning that patients with type 2 trigeminal neuralgia often started with type 1 trigeminal neuralgia, and over the years, the pain has merged into a type 2 scenario. We'll talk about trigeminal neuropathic pain and what that means. We'll talk about trigeminal deafferentation pain and what scenarios that occurs. We'll talk about symptomatic trigeminal neuralgia from multiple sclerosis, which is a rare but discrete subset of trigeminal neuralgia. We'll talk about post-herpetic trigeminal neuralgia, and then we'll talk about what's classified as face pain of obscure etiology. This facial pain system was developed by a neurosurgeon, Dr. Burchell, who came up with this system in order to stratify the patients. It is not the only facial pain classification system out there, but I found over the last 10 years, it's the one that makes the most sense in terms of how it breaks the patients down into the categories, and I think it's the easiest to understand. It's probably also the most common type of face pain that's offered. Okay, so type 1 trigeminal neuralgia is the most common type. It's what the literature often refers to as classic trigeminal neuralgia, and this is identified as face pain of spontaneous onset. So the patient will describe that they were in their, they didn't have any facial pain, and then gradually over the course of months, there was an onset of electrical shock-like pain. It came and went. Initially, the pain was very infrequent, and now it's become more and more frequent. So there's typically no precipitating episode. They've not had any head trauma. They've not had any facial surgery. They've not had any infections. Just the pain seemed to come on spontaneously. During the initial portions of type 1 trigeminal neuralgia, patients often do not require any treatment, not even pain medication. So, and this is because the pain maybe only bothers them a few days every month. So it doesn't make sense to take medication if the pain is that infrequent. Often during this phase, the pain can disappear for periods of time. And it's not uncommon to hear stories of patients that had pain for several months and then it went away for a year or so before coming back. In type 1 trigeminal neuralgia, the pain does gradually become more frequent. And by more frequent, we start to see more and more attacks per day. A key point, however, and is that their patient does experience pain-free episodes between the attacks. And this is something that I often ask patients about, like, are you ever pain-free? And most of the time the patient interprets that as, you know, are you ever free of your pain completely? And they say, no, I have it all the time. But when I specifically say, is there any period of a 24-hour day where if you're sitting quietly, not talking, not moving, you don't have pain? And if the answer is yes, then that's a pain-free period. The pain is typically described as sharp, lancinating pain. It is often described as electrical shocks, a stabbing pain, ice pick type of pain. And the way patients describe it, they often use it in various different terminologies, but they all come to the same description, which is it's a sharp electrical type of pain. One of the things that we look for is whether or not the patient has triggers as part of their pain. And triggers include eating. Typically, when a patient eats food, the pain comes on. As a result, some patients end up eating less and may become nutritionally compromised, and this can result in weight loss. So in extreme situations with trigeminal neuralgia, a patient can report losing 5-10 pounds a month because they're unable to eat. I have seen over the years extreme cases where patients are essentially cachectic, very thin, from extensive weight loss from trigeminal neuralgia pain. And in those situations, the pain becomes almost more of a the situation becomes almost more of a crisis because the patient's going to get into trouble from nutritional deficiencies. Face washing is another common trigger for the pain. In this situation, the patient reports they may wash their face with soap or a cloth. The pain becomes triggered. Water in the shower triggers the pain. Talking is also a common trigger. We see this when patients are in clinic trying to describe their pain to us. They often have episodes of pain during the actual clinic visit because of the talking required to describe the pain. We talk about touching their face that can trigger pain. I've had situations where parents will say that, their child runs up to them and gives them a hug and touches their face, they get pain triggers. Even a light touch, graze on the face can trigger the pain. Wind is also a common trigger. Typically, if a patient's outside and wind starts blowing on their face, that can trigger the trigeminal neuralgia type of pain. So we look at this description of the pain, we look at the triggers, and we get a good idea of whether or not they have this, what we call type 1 trigeminal neuralgia. This is usually caused by a blood vessel touching the trigeminal nerve. And in this situation, we often go with an MRI scan to look for the blood vessel. So, and this is a series of MRI scans, and in this MRI scan, this is called a Fiesta sequence. And for some of you who've heard my prior talks, I talk about the importance of getting the right MRI sequence. Most of the MRI sequences are not useful to look at the trigeminal nerve carefully, but in Fiesta MRI sequence, we can see the intricate details of the trigeminal nerve. So we commonly get this sequence prior to planning any treatment options for the patient. So let's talk about treatment for type 1 trigeminal neuralgia. There's a list of treatments here. I'm going to start with just basically talking about medication. It's not on this list, but I think it's the the first line of treatment. So early on in trigeminal neuralgia, medications tend to work very well. So medications such as carbamazepine, which is generic name for Tegretol, or gabapentin, which is also called Neurontin, are probably the two most common types of medications used to treat trigeminal neuralgia. Now, I often use their patient's response to medication as an important clue in terms of whether they have type 1 trigeminal neuralgia. Why would that be the case? We know that with type 1 trigeminal neuralgia, the patient should respond in nearly all circumstances to the pain medication, meaning that they should have improvement in their pain. That's not saying that the pain medication is the long-term solution or that that's the only treatment that they would qualify for. What I'm saying is that if a patient takes these medications and they say it actually temporarily made my pain better, that is a good sign that favors type 1 trigeminal neuralgia. If the patient takes standard trigeminal neuralgia medication and they do not have a response to that medication, that actually steers me away from type 1 trigeminal neuralgia, because if you did have type 1 trigeminal neuralgia, you should have responded to the pain medication. So if you do not have a response, that may be a clue that you don't have type 1 trigeminal neuralgia. Now, in terms of the different treatments, we can see them listed here. I'm going to talk first about microvascular decompression. This is a surgical procedure where you move the blood vessel off of the nerve. As I mentioned, that is the primary cause in type 1 trigeminal neuralgia. It is the treatment that has the best chance of achieving long-term permanent relief of symptoms if you do have type 1 trigeminal neuralgia. And that is because you're actually dealing with the root cause of the problem. You're moving the blood vessel off of the nerve. The advantage of this treatment is that it tends to result in immediate pain relief in the majority of patients that have the procedure. Typically works about 90% of the time in patients. And it also tends to be durable, meaning that if you have pain relief, it tends to be lifelong. Not necessarily in all patients, but the majority of patients that have pain relief have long-term pain relief. The primary downsides of the microvascular decompression, it's a surgical procedure. It takes about 3 hours to do. Most of the time patients are in the hospital for just a couple of days. At least that's the way it is in my practice. And typically, significantly improves the quality of life by eliminating the pain. It allows the patients to get off the pain medicine. Most of the time, the pain medicines, even when they do work, create some side effects such as drowsiness. So the microvascular decompression allows us to get the patients off the pain medication. Stereotactic radiosurgery is the next possible treatment for type 1 trigeminal neuralgia. In this treatment, you are delivering a focused beam of radiation to the trigeminal nerve. In essence, what you're doing is you're damaging the trigeminal nerve with this radiation. And by damaging the nerve, you're actually disrupting and damaging the pain fibers in that nerve. So the nerve can no longer conduct the pain, and that allows the relief of trigeminal neuralgia. The primary advantage of the stereotactic radiosurgery is that it is an outpatient, non-invasive treatment. So unlike the microvascular decompression, which is a surgical procedure done in the operating room, the stereotactic radiosurgery is an outpatient procedure. The things to know about radiosurgery is that it also results in initial 90% improvement in pain in patients. But what happens with this pain relief is that when it does occur, it tends to not be necessarily long-term and durable. Now, why would that be the case? The reason for that is your body does not understand that the damage that was done to the nerve was done for a very deliberate reason, which is to eliminate pain. In essence, what happens is your body thinks this injury is like any other injury to the body, and it can start to repair itself. So the nerve repairs itself, and those pain fibers that you damage with the radiation can get repaired. And so radiosurgery results in a initial high pain relief, but then this declines over time as the nerve heals itself. So with radiosurgery, after 5 years, 50% of patients that have had pain relief, the pain has come back. The other disadvantages of radiosurgery is that the onset of pain relief can take a while, because it can take a while for the radiation to damage the nerve. In many instances, the pain relief can start in 2 to 4 weeks, but in a few patients, it can take up to 5 or 6 months to have the full benefit of the radiation treatment. The stereotactic radiosurgery also, by damaging the nerve, damages the sensory fibers in the nerve. So the trigeminal nerve has both pain fibers and sensory fibers, and by damaging the sensory fibers in the nerve, you will get some potential numbness in the face. So I typically quote a 30 to 50% chance of some numbness in the face with the radiosurgery, whereas the microvascular decompression surgery is only about a 5% chance of numbness in the face. So again, the advantages: outpatient and non-invasive, and an initial high success rate. Disadvantages: higher chance of pain coming back than the microvascular decompression, higher chance of facial numbness, and a delayed onset of pain relief. The third treatment is what's called radiofrequency rhizotomy. This is a treatment, I call it the needle in the cheek procedure, because what you do is you direct a needle through the cheek tissue up to where the trigeminal nerve comes out of the base of the skull. And rather than using radiation to damage the nerve, you actually use heat to damage the nerve. So radiofrequency rhizotomy still achieves the same result of pain relief, and it's initially 90%, just like the other two treatments, but it's using heat instead of radiation. It works a lot faster than radiosurgery. It's usually immediate, but the primary downside is that typically results in even a higher chance of facial numbness. So we typically see 75, maybe even 90% chance of some facial numbness with this radiofrequency rhizotomy. And while patients will say, for the most part, that they will take numbness over pain any day of the week, what typically happens is after their pain is gone and they've kind of lost the memory of how bad the pain is, they start focusing on the numbness. And so you can have a patient come to see you a year later, their pain's gone, but now they're starting to complain of numbness. Balloon compression is another treatment that's done where essentially you're inflating a balloon next to the nerve, and the inflated balloon compresses the nerve and damages the nerve with just mechanical compression rather than heat or radiation. Glycerol injections are also done. Glycerol is it's an alcohol solution that can be injected into the region around the trigeminal nerve and essentially results in some irritation and damage to the trigeminal nerve, so it doesn't conduct the pain. Similar to the radiofrequency rhizotomy, the glycerol injections have a higher failure rate than either the microvascular decompression or stereotactic radiosurgery in terms of recurrence of pain down the line. Surgical rhizotomy is not commonly done anymore. This is essentially a procedure like the microvascular decompression, but instead of moving the blood vessel off of the nerve, you're essentially cutting the nerve. And the reason why it's not commonly done is that obviously once you cut the nerve, you've anatomically disrupted the nerve. This will result in the numbness to the face. And once you cut the nerve, there's no way to really put the nerve back together. So let's switch gears a little bit to talk about type 2 trigeminal neuralgia. As I mentioned, this is usually an evolution of type 1 trigeminal neuralgia, meaning somebody had type 1 trigeminal neuralgia for many years, and then over time it became type 2 trigeminal neuralgia. So what is the line that separates type 1 and type 2? It has to do with the type of pain that the patient has. So if the patient describes the electrical shock-like pain as the predominant type of pain, that would be type 1 trigeminal neuralgia. If the patient says, I have electrical shocks, but they really only represent about 25% of my pain. And the other 75% of my pain is burning and aching and throbbing. Then they have type 2 trigeminal neuralgia. So again, we look at the electrical shocks. If the electrical shocks are more than 50% of your pain, you have type 1 trigeminal neuralgia. If the electrical shocks are less than 50% of your pain, you have type 2 trigeminal neuralgia. So you can have some electrical shocks with type 2 trigeminal neuralgia, but it's less than 50% of the pain. So with type 2 trigeminal neuralgia, you can still do the same workup. You get the MRI scan. You can look for a blood vessel touching the nerve. We have the same options available to the patients that I discussed for type 1 trigeminal neuralgia. But generally with type 2 trigeminal neuralgia, I tell the patient the goal is to try to eliminate the sharp electrical shock component of the pain, and the more dull, achy pain that's kind of in the background may or may not improve. So that's type 2 trigeminal neuralgia. And I talked about how, when we do the MRI scans, we're looking for a blood vessel touching the nerve, but we're also looking to see if there's any other findings. So this is a patient that had a large tumor that was surrounding the trigeminal nerve, and they had type 2 trigeminal neuralgia, burning type of face pain. So in this situation, it's not as straightforward. Manage the trigeminal neuralgia. It's how we're going to manage this patient's tumor. So type 3 facial pain is called trigeminal neuropathic pain. And so neuropathic pain is pain that develops as a result of injury to the trigeminal nerve. So the nerve was somehow injured, and when it healed, essentially scar tissue formed, and that caused the nerve to maybe heal incorrectly or not fully normally, and that causes this neuropathic pain. So situations that can result in this type 3 pain or trigeminal neuropathic pain could be injuries such as facial trauma. You're in a car accident and your face hit the windshield and that caused injury to the trigeminal nerve. It could be from surgery. Sometimes when you do surgery, you can expose the trigeminal nerve, and maybe the scar tissue from the surgery heals around the trigeminal nerve in such a way that it causes pain. I've seen patients that have had strokes in regions of the brain, specifically involving the trigeminal nerve, and then that's caused trigeminal neuropathic pain. So the pain is usually described as a very burning, unremitting, throbbing type of pain. So there's pretty much no electrical shock component here. And the key to differentiate this type of pain from the other types is there's a precipitating event. There was a trauma to the head, there was a procedure, some surgery, there was some event that happened that led to the pain. And you can pretty much pinpoint the start of the pain to that particular event. So it's a little bit hard to see in this slide here. This is actually a patient from several decades ago that I saw some films on. And this patient was a 71-year-old woman who developed a stroke. And the stroke showed up as a very tiny stroke, about the size of a green pea, that occurred right where the trigeminal nerve was located. And that, as a result of that, the patient developed trigeminal neuralgia. So there was a precipitating event. There was a stroke. They woke up one morning and had numbness in the face that turned into pain. And you had an MRI scan that showed evidence of that stroke. So type 4 pain is trigeminal deafferentation pain. So if you remember, type 3 was pain that resulted from some sort of trauma or maybe a surgical procedure, and the trigeminal nerve was just an incidental bystander in that situation. Type 4 pain means a direct injury to the trigeminal nerve itself from a prior procedure on the trigeminal nerve. So this is either surgical treatment of the nerve, a rhizotomy to the nerve, a glycerol injection to the nerve that caused, you're trying to injure the nerve to alleviate the pain, maybe type 1 trigeminal pain, but in turn, the patient over time developed type 4 pain. So again, this pain is there's a really not necessarily electrical shock-like component. There's just a burning, itchy type of pain, crawling type of pain. Some of you may have heard of the term anesthesia dolorosa. This type of pain falls into this category of type 4 trigeminal deafferentation pain. Trigeminal neuralgia has been considered kind of the worst, some of the worst pain that somebody can ever encounter, but anesthesia dolorosa is probably the one type of pain that's worse. It's very rare, so we don't see it that often, but it's this really sharp pain, excruciating pain in an area of the face that's also got some numbness going on. So it's kind of this bizarre scenario where the patient reports numbness, but they're also reporting severe pain in the region of the numbness. And as I said, this is fortunately very rare, but it's a situation you don't want to end up in because there's not really good treatment options for anesthesia dolorosa. Type 5 pain is trigeminal neuralgia that occurs from multiple sclerosis. So how does this happen? So multiple sclerosis is a inflammatory process in which your body develops antibodies that attack some of the lining of the nerves. So it's kind of you can think of it as kind of an autoimmune process. And multiple sclerosis is responsible for about 2% of patients with trigeminal neuralgia. So we talked about earlier how we get an MRI scan. The MRI also can tell us if we're dealing with a multiple sclerosis situation. So about 2% of patients with multiple sclerosis have trigeminal neuralgia. If you look at the flip side, if a patient has trigeminal neuralgia, what's the likelihood they have multiple sclerosis? It's also about 1 or 2% as well. So this pain could be electrical shock-like pain, like we see in the type 1 trigeminal neuralgia pain, but it could also be a constant pain as well. And when you do the scans, you see this multiple sclerosis lesion. We call it a demyelination lesion. It shows up on the MRI scan as a discrete spot. Now, in patients that have trigeminal neuralgia that are younger than the age of 40, we often consider multiple sclerosis because it just is a higher probability of happening in the younger age group. And again, MRI scans will provide evidence of multiple sclerosis. So in this picture here, we see, this is from one of the Mayo Clinic illustrations. You see at the top, there's a normal nerve. The normal nerve is in the center and it's surrounded by a protective sheath. So I like to think of this as one of those older cable wires, copper cable wires that's surrounded by a rubber sheath. So during multiple sclerosis, you can see that the body attacks the lining of the nerve and destroys it. And that's the damaged myelin that's present there. And that exposes the nerve or exposes the copper wiring, and that can lead to pain that can come on. Type 6 type of trigeminal pain is post-herpetic trigeminal neuralgia. And this is, it's a viral type of pain. It's herpes zoster virus, same situation that can cause like shingles, but it occurs along the trigeminal nerve. And I put this little picture in the lower left corner showing the cartoon of the patient's face. There's 3 branches of the trigeminal nerve. Many of you have heard of V1, V2, and V3. So 5 is the Roman numeral, V is the Roman numeral for 5. And so we classify the branches as V1, V2, and V3 because the trigeminal nerve is the 5th cranial nerve. So V1 involves the forehead, that's the ophthalmic branch. V2 is the maxillary branch, involves the cheek, kind of below the eye, by the nose. And V3 is the mandibular branch. It's the branch that involves the chin there. This causes a burning type of pain. There's typically no electrical shocks. And you can pretty much diagnose this because the patient will describe that they've had an outbreak of the virus. The virus, the pain comes on, you can really link one to the other and make a diagnosis that way. This is a classic example of how it's important to categorize the type of pain, because in this situation, the pain's from the virus. You're not going to be really looking for a blood vessel touching the nerve like you would in the type 1 trigeminal neuralgia. So last is what's called face pain of obscure etiology. And like any classification system, there has to be one last bucket to put everything else that doesn't fit in the other categories. And that's this category, category 7. Obscure etiology means unknown or unclear cause. And so everything that doesn't fit into categories 1 through 6 falls into this category here. It's generally the face pain typically doesn't match normal anatomic borders. I showed you a picture of how the pain is distributed on the face. So a patient like this would say, I have pain on, my head, my back, my neck, all the way down my arm. I mean, the pain will be more than just the trigeminal distribution. They describe it as being very disruptive to their lifestyle, but they don't have the triggers. Ask, can they eat? Yes, I can eat. Can you wash your face? Yes, I can wash my face. Does wind bother your face? No. Did the pain medications that we use for trigeminal neuralgia work? No. So really nothing kind of matches together for some of these type of obscure etiology type of pain. So in this type of situation, if you have a patient in this category, you would not recommend radiosurgery or microvascular decompression because of just the nature of their pain. So I'm gonna stop here and basically spend the second half of the talk just answering questions. So if anybody, I think there were a few questions that were submitted, so I'll go ahead and take a look at these questions. So the first question that came in, it talks about when would be a good time to start considering microvascular decompression surgery, and should you take age into consideration? So that's a very good question. So we know that over time, if you have classic type 1 trigeminal neuralgia with electrical shocks, that is the best chance of having a good outcome with microvascular decompression surgery. So in other words, if you have 2 patients, one patient has had trigeminal neuralgia pain for 1 year, it's still electrical shocks, and a second patient has had trigeminal neuralgia for 20 years, they really have very little electrical shocks, it's mostly a chronic achy pain. Of those 2 patients, the first patient would have a better chance of having a good outcome with microvascular decompression. Why is that? Well, they have type 1 trigeminal neuralgia, not type 2. Type 1 responds better to the type 2. And secondly, just if you think about it, the problem is the blood vessel pushing on the nerve. The best chance of having a good outcome would be a situation where you get the pressure off the nerve sooner rather than later. So if you can get the nerve decompressed after a year or 2, it sort of makes sense that that patient will do better than a situation where the nerve is being pushed on by the blood vessel for 25 years and then expecting somehow a decompression to offset 25 years of pressure and injury. So there is some data that shows that you have a better chance of a higher likelihood of a completely being pain-free if you do the decompression surgery earlier when you have the type 1 trigeminal neuralgia, the electrical shock-like pain, and not a component of the achy pain. The second part of this question was, should you take age into consideration? I think age is somewhat of a factor. I worry less about chronologic age and worry more about kind of just the functional age of the patient, meaning what kind of shape the patient is in. I've done trigeminal neuralgia, microvascular decompressions in patients in their 90s. If they've been in good health. Alternatively, if you run into a situation where you have even a younger patient, if they have some medical problems, heart disease, lung problems that prevent them from having a general anesthesia, then oftentimes those are the patients we will look at stereotactic radiosurgery or one of the other treatment options. So, age comes into play in the sense that if you have too many other medical problems as you get older, that may eliminate the opportunity to do a microvascular decompression. The next question is, if trigeminal neuralgia was caused as a result of oral surgery, should this type of pain be treated differently than type 1 trigeminal neuralgia? So that's a good question. And so if you had dental surgery and that caused trigeminal neuralgia, there's kind of two broad categories of thought here. The first category is that, if you have dental surgery and you have the pain, you no longer have type 1 trigeminal neuralgia. You have that type 3 trigeminal neuralgia that I talked about. There was some trauma to the head, and the trauma could be like a head trauma, or it could be a surgical procedure, but that somehow caused impact to the trigeminal nerve, and that resulted in the pain. Having said that, if the pain is electrical shocks, then you still may have enough of the component of type 1 trigeminal neuralgia that a microvascular decompression can be considered. And why would that be the case? There's a thought that the trigeminal nerve may be impacted at several points along the length of the nerve. So you have a situation where you have a blood vessel pushing on the nerve, but maybe the nerve's strong enough, it doesn't become impacted by that blood vessel. But now you have some dental work, and now you have the nerve injured in two locations. One inside the skull with a blood vessel pushing on the nerve, and a second location in the mouth from the dental work. So now the nerve is hit twice, and maybe that's enough to push it over the edge. In those situations, if you did decompress the nerve with a microvascular decompression surgically, that might be enough to improve the pain because you're alleviating the one of the two hits on the nerve. So that's called a two-hit theory. The nerve's okay as long as it's just being hit in one location, but if you hit the nerve in two locations, then you have a problem there. This type of scenario requires a lot of individualized, personalized evaluation of the patient, how much of their pain is still type 1 trigeminal neuralgia. And then it'll boil down to kind of just the statistics. I typically try to just talk to the patients that I see and give them probabilities. So if you had this scenario, I think there's a 70% chance that the microvascular decompression would help, for example. I'm just made up that number for this example, but let's say that's what I put out there. Then it's up to the patient to decide whether that number is sufficient enough for them to make a decision to go ahead. Some patients would say, I only want to have a procedure if I'm up around 90% success rate. And other patients will say, well, my pain's so bad that, anything above 50% is something that's worth considering. So it's very individualized when it comes to that. So the next question is, why not take the medication just daily? I'm taking carbamazepine 300 milligrams 2 times a day. The short answer to that question is that yes, you can take the medication every day as long as it continues to work and as long as you don't have side effects. So there are some patients where the medications work for many, many years, and other patients where the medications don't work for very long, or they have too many side effects. So this really boils down to, are the medications working? Now, let's say the medications are working for you. What's the likely long-term course here? Generally, the medications typically become less and less functional in terms of their ability to help the patient over time. So what the usual story is the patient says, I started the medications, they worked great. 6 months later, the pain got worse. I upped the medications, it worked great. Another 6 months went by, I was at the maximum dose of the medications and I'm still having pain. So medications typically over time become less effective. It may take years or it may take months, but as long as the medications are working and you're not having the side effects, then you can certainly take them every day and not go to the procedure stage. The main side effects of the medications are drowsiness and kind of cognitive fogginess. And so many patients say, I'm taking the pain medicines and it's working, but when you really start to ask them, are you able to think clearly? Are you able to be focused? Do you have the energy you want? They'll start saying, well, actually, I'm not thinking that clearly. I don't have that much energy. And those are side effects of the medication. So If the medications are working, you just have to decide if that is, worth it with potential side effects if that's what you have. The best course, next question, what's the best course of treatment for trigeminal neuralgia caused by multiple sclerosis? Again, this is a highly individualized situation because in some patients with multiple sclerosis, I will still offer them either a microvascular decompression or stereotactic radiosurgery. Depends what I see on the MRI scan. If they have multiple sclerosis and they have trigeminal neuralgia, but the MRI shows a very clear-cut blood vessel pushing on their nerve, they likely are still going to be a candidate for microvascular decompression. If we don't see any blood vessels touching the nerve, we will often in those situations offer the patient the stereotactic radiosurgery as a treatment option. So it is going to be individualized based upon what we see on the MRI scan, but it's not the situation that if you have trigeminal neuralgia from MS that there's no treatment options available. The next question says, what's the impact of taking drugs daily for years? This is for glossopharyngeal neuralgia. So glossopharyngeal neuralgia, just as a side note, is a different nerve, but essentially it's the same situation where you have a blood vessel pushing on the nerve. This causes pain in the back of the throat, so where the tonsils are located. And so it hurts a lot when they swallow or drink as opposed to having the pain on the surface of their face. As long as the medications are working, these are medications that are designed to be taken for extended period of time, including years. So the short answer to your question is that, again, as long as they're working, no problem taking it for years and years and years. The more complicated answer, as I just mentioned, is that, when a patient says that their medications are working, they're usually talking about pain relief. They're not talking about, side effects of the medications, which can significantly impact quality of life. Next question is it possible to have MS and also have a blood vessel compressing the nerve? Would an MRI show if both were occurring? Yes, that would be the case. You can have MS and a blood vessel compressing the nerve, and an MRI would potentially show both multiple sclerosis and the blood vessels. And as I mentioned in one of the prior questions, you then have to individualize it to the patient to determine whether or not the treatment options make sense. In many cases, they do. But I think the probability of success needs to be scaled back a little bit. So if I see a patient with MS and we're talking about a microvascular decompression and they have a blood vessel touching the nerve, I will typically quote them about a 75% chance of success rather than the 90% that if they had straightforward, pure trigeminal neuralgia. The next question is, what is the best treatment for combined trigeminal neuralgia type 2, intermittent burning from old head trauma, and trigeminal neuralgia type 3 with more recent years of occasional electrical shocks? So this is getting to be this is kind of more of a tougher question because, you're talking about possibly two different buckets of pain. And generally, if you end up falling into two buckets of pain, it usually means that the pain is not as well classified in your situation as it would be for other patients. The procedures that I discussed today are designed to eliminate the electrical shocks. So if this is a situation where most of the pain is intermittent burning pain and there's electrical shocks, or let's say only 5 or 10% of the pain, there may not be some good. The procedures I discussed may not have a high chance of helping, and in most of those situations, patients will decline, a surgical procedure or a radiation procedure. There are some potential treatments with the rhizotomy in this situation that some of my colleagues in the Stanford Pain Clinic have been doing, but again, it's going to be highly individualized based upon what other treatments you've had and what were the results of those treatments. Did you have this procedure or that procedure, and did it work even if it's for a short time, or did it not work at all? So that would have to be highly individualized. Next question is it common to have a swelling on the face during episode of trigeminal neuralgia pain? The short answer to that would be no. The trigeminal pain typically does not cause facial swelling. In a few patients that I have had, I've seen swelling in the face that can happen with trigeminal neuralgia, but that's due to some sort of vascular flushing syndrome that may parallel the pain rather than directly from the pain itself. The next question says, I have type 2 trigeminal neuralgia. Nothing is shown on 2 Fiesta MRI scans. A neurosurgeon I saw said no to microvascular decompression, but yes to gamma knife. The episode started in April of this year. I've been on multiple medications. I had a nerve block, acupuncture, occipital blocks. I'm 39 years old. In your opinion, would you recommend gamma knife? So the Fiesta MRI scans are designed to show whether there's a blood vessel compressing the nerve. They've gotten very good in recent years in terms of their ability to detect a nerve is not quite 100%, but pretty far up there. So generally, if you've had 2 MRI scans with Fiesta sequences and you don't see a blood vessel touching the nerve, it probably means there's not a blood vessel in that area. So if you did a microvascular decompression, it's essentially would be exploratory and you're likely not to find anything. So in those situations, we cross that off the list. And so now you're going to those other procedures, and the radiosurgery, the gamma knife is a form of stereotactic radiosurgery, the second treatment I discussed. That still could be considered, and you would actually use the Fiesta MRI scan to target the delivery of the radiation. So in this situation, you've tried other treatments, you've been on the medications, you've had the nerve block, you've had acupuncture. So this is a situation where it depends really how much trouble the pain's causing. If it's really significantly debilitating and impacting your quality of life, then you certainly a gamma knife procedure or radiosurgery is an option. Because you've had other treatments that have not resulted in a successful resolution of your pain, I would ratchet back the success rates for the radiosurgery a little bit, because when we see situations where prior treatments aren't working, that usually is a clue that the standard treatments that we have may not quite be as effective. Next question is Depakote a good option for trigeminal neuralgia? It's a medication that can be used. It's usually not the first line medication, but if you've had side effects to either the Neurontin or the carbamazepine, Depakote can be tried. And I'm of the belief that if you try it and it works and you have no side effects, then there's nothing wrong with going that route. If it works, it works. Next question is, which type of trigeminal neuralgia do I have? If I have episodes of electrical piercing pain to 2 of the branches, I'm unable to wash my face in the shower, wind triggers a pain. So by description, it sounds like this would be type 1 trigeminal neuralgia so far. Electrical pain, you have the triggers, the wind, the touching of the face, etc. You've had, have microvascular decompression procedure twice and was told that is a vessel pressing on the trigeminal nerve. I do have numbness to the cheek on the right side of the tongue as a result of the second microvascular decompression. Now I'm on Lyrica and it helps a lot. Do I have type 1 or type 2? Again, we don't use prior treatments as a description in classifying trigeminal neuralgia face pain types. So I would reading this, I would in my mind, I would eliminate the sentences about microvascular decompression because that doesn't have any bearing. And I would just look at your description of the symptoms. You have electrical shocks, you have the triggers, and the pain medications work. Those are all 3 signs that favor type 1 trigeminal neuralgia. So that's the type that you would have based on just the description. The only thing that kind of moves away from your type 1 trigeminal neuralgia is you have had 2 microvascular decompression procedures, and we're told there's told that's a blood vessel pushing on the nerve. It sounds like that they presumably packed off the blood vessels and it didn't result in pain relief, which would be the only factor going away from type 1 trigeminal neuralgia. But based on just your other description, this is type 1 right now. Next question is there a way to identify the glossopharyngeal vascular compression on a Fiesta sequence? The answer to that question is yes. The glossopharyngeal nerve is very, very easily seen on a Fiesta sequence. And essentially you do the same thing that you do for trigeminal neuralgia, and that you look for a vascular compression syndrome. So you look for a blood vessel touching the glossopharyngeal nerve. And if you see that, then the patient's a candidate for a microvascular decompression of the glossopharyngeal nerve rather than the trigeminal nerve. Glossopharyngeal neuralgia is probably for every 50 to 75 patients with trigeminal neuralgia, you have one patient with glossopharyngeal neuralgia. So it's not as common by a magnitude of 50 to 75 to 1 ratio. The next question is, what are the recommended next steps if the medication side effects are affecting the quality of life, but the medication is keeping the pain under control? So this is actually a very good question because it comes back to the issue of when do you consider a procedure like a microvascular decompression. So I consider the surgical procedure in 2 situations. One is that the pain is not controlled with medication. That's pretty straightforward. Medications aren't working, let's consider a procedure. The other situation is the medicines are working, but I'm having so many side effects from the medications that my quality of life is poor. So on some of these trigeminal neuralgia medications, I mentioned some of the side effects, the cognitive confusion, the fogginess of the brain, the lack of energy. Patients often report dizziness, imbalance when they walk. And they're very fatigued. So a patient may be in a situation where they're completely, or nearly completely pain-free, but they're sleeping 16 hours a day. And when they are awake, they're really not focused. Their mind is foggy. In that situation, this is a quality of life issue. If a surgical procedure gets you off the medications and restores your quality of life, then certainly, yes, you want to consider it. Now, of the patients that I see with trigeminal neuralgia that I personally do microvascular decompressions on, I would say at least half of the patients are choosing the procedure because of the side effects of the medications rather than the actual pain they're having. So maybe something like 40% of the patients are choosing an MVD in my practice because of unrelenting pain, that the medicines aren't working, and 60% are choosing the microvascular decompression because they're having too many side effects from the medications. Okay, the next question is, my eyes water on my trigeminal neuralgia side. Is that normal? The side of my tongue also feels sore, almost raw during a flare-up. There's nothing to feel or physically to see. That is that normal? So I've seen this happen, both the eye watering and the tongue situation in some patients with trigeminal neuralgia. I'm not sure if I fully understand how the interaction takes place, but it's something that I've seen happen before. But I can't explain in kind of more detail the rationale for why that happens. Okay, I think I've gotten through all the 14 questions that have come in. I'm happy to answer any other questions that, there's another question. Your practice focuses neurosurgery and procedures. Are there specialists at Stanford that just work with trigeminal type 2 and type 3 pain? Yes, we have a formal facial pain program at Stanford that includes about 20 different physicians, including neurosurgeons, neurologists, pain specialists, ear, nose, and throat physicians, dentists. So we have the full gamut of specialists for this. And so if you're referred to Stanford for trigeminal neuralgia and it's not a procedural situation, then in those situations, your referral will be routed over to, for example, a neurologist that specializes in managing these from a medication standpoint. Okay, all great questions. Any other questions that people have before we conclude our presentation? Okay, here's one more question. I'll answer this one. I think then we can wrap it up. I have Kaiser will be seen by a neurosurgeon in Sacramento, Roseville area. Any thoughts? So generally, the comments I would make about this are pretty much common sense comments, and that comes down to this: is you're best managed by somebody that has a expertise in trigeminal neuralgia, that sees many patients with trigeminal neuralgia, that does many procedures. Like if they do microvascular decompressions, they do a lot of them per year. If they do the radiosurgery, they do a lot of it per year. Because you want somebody that has an interest in trigeminal neuralgia and has the experience and expertise in trigeminal neuralgia. Many of you probably know that, oftentimes when you're initially diagnosed with trigeminal neuralgia, the diagnosis may be delayed. You may be bounced around from either dentist to dentist or doctor to doctor because people don't understand the diagnosis. And that's because you're seeing physicians that really don't have the experience and understand what trigeminal neuralgia is. If you see somebody with experience with trigeminal neuralgia, they will rapidly be able to make the diagnosis, determine which kind of category you fall into. So I think if you're seeing a neurosurgeon in Sacramento, the bottom line is just make sure that the physician you see has an interest in trigeminal neuralgia, has a lot of experience in trigeminal neuralgia, and knows kind of how to manage that.